Welcome to Value-Based Care Insights, brought to you by Lumina Health Partners, a national healthcare consulting firm focused on improving the strategic, financial, and operational performance of provider organizations. On this program, we will explore trends and share valuable insights on how health systems and medical groups can optimize their performance to meet the demands of this increasingly complex healthcare environment and shift to transform the delivery of care. Value-Based Care Insights is hosted by Daniel Marino, Managing Partner of Lumina Health Partners. Daniel has been in the industry for over 3 decades and specializes in shaping strategic initiatives for organizations in areas such as population health, clinical integration, physician alignment, information technology, and data analytics. For additional insights, visit luminahp.com and sign up for our newsletter. Dan, over to you.
Welcome to Value-Based Care Insights. I am your host, Daniel Marino. In today's topic, we're going to spend some time talking about the changing anesthesia market and a lot of the pressures that we're seeing from our industry, either as a result of anesthesia activities that are occurring, maybe the shortage of anesthesiologists, anesthesia providers that are across the country, as well as the economic pressures. In many hospitals, surgical services remains, if not the largest generator of revenue, it's certainly number 2. And yet anesthesia is such a critical component to providing that level of surgical services, not just in the hospital, but also in the surgery centers. So many hospitals are actually expanding their surgical services, accommodating the services in the acute arena, but also in the ambulatory area. Well, I'm really excited today to have 2 wonderful guests, 2 great colleagues. Tim Hanners, who is a former hospital executive and has been working in the anesthesia space for a number of years, has helped quite a few organizations around the country, helped to improve and work through a lot of their anesthesia economic challenges, as well as a lot of the operational challenges. I also have Dr. Dave LeBec, and Dr. LeBec has been the Chief Medical Officer for a national anesthesia service company. Again, has worked with numerous organizations around the country from the provider perspective, just really helping to align the incentives and create a lot of clinical as well as operational efficiencies. Tim, Dave, welcome to the program.
Thank you, Dan. Thanks for having us on here. And by the way, Dave is an anesthesiologist, which is important to this. And I have to give further introduction to Dave because he won't do it himself. He's too humble. But Dave has a unique perspective of being, as you mentioned, heading up national anesthesia provider groups across the country and seeing things at that 30,000-foot view. But also, he continues to work clinically as locum tenens, et cetera. So he's seeing it from inside the ORs as well. So
yep.
Glad to have Dave on here.
Appreciate that, Tim. And yes, Dave, forgot to mention that obviously practicing anesthesiologist is important. So maybe we could start with you, Tim. Real quick, what are you seeing are some of the real challenges that healthcare providers are struggling with as they're thinking about maybe either realigning some anesthesia services or just responding to some of the surgical needs that they have within their community?
Yeah, so you hit it. The hospital administrators, CEOs, and in particular CFOs are really struggling right now. They're very frustrated because you're right. Traditionally the OR has been a real driver for financial performance for everything, and there's some things that are a bit out of their control because the payers, of course, the financial margins of the OR shrank. And are shrinking greatly. And then there's some other factors where a lot of their OR business has gone to ASCs.
Sure.
And that's, of course, been orthopedic, but a lot of other things are moving to the ASC procedures and surgeries.
Right. So we're seeing that shift in site of service. So, Dave, I can't help but think that this puts probably the anesthesiologist in a real difficult position, right? I mean, to one extent, it's always great to be needed. And yet, and I'm sure they can get pretty much roles anywhere, but they have to be, I would think, certainly professionally challenged on really meeting the needs of the provider organization and even their surgical counterparts.
Yeah, so first of all, thanks, Dan, for inviting me for this great topic today. And yes, you're correct. In the post-pandemic world, we've seen a shift in how providers both perform their duties, anesthesiologists as well as CRNAs, roles expanding, roles changing. We've also seen a shift in the employment models, which we're going to talk about today as well. And the primary kind of stressor we see is that anesthesiologists still want to take care of their patients, work with their surgical colleagues, yet sometimes they do feel they're caught in the middle of a battle between, say, a national service provider company as well as the hospital. And they feel that sometimes this creates a barrier to them providing the care they need for the patients that they see each day. And importantly, I think we mentioned already by Tim, the expansion into this ambulatory surgery centers as well. Prior to the pandemic, surgery centers were often taking care of lower acuity patients with a small, diverse, not so diverse set of surgical procedures. But now we're seeing the rapid expansion of surgery centers, some with 24 to 48-hour stays, doing more complex procedures that require different skill sets.
Sure.
So we're seeing these surgery centers expanding with a higher demand for higher sets of skill sets, and yet a national shortage of anesthesia providers, both CRNAs as well as anesthesiologists. So as you can see, there is a production pressure as well as a service pressure that's placed on all the providers.
But you made one interesting comment, Dave, that I want to dive into a little bit. So are you starting to see more of a trend towards employment? And if so, why is that the case? Is it because of those economic pressures, or do hospitals feel like they could, I don't know, create a better relationship with their anesthesiologists and align that with the surgical providers? What's the big driver of this?
Great question, Dan. And what we're seeing is a shift of more towards the employed model by the hospitals. Traditionally, this has not been a very appealing model to anesthesiologists or CRNAs in the past prior to the pandemic, as hospitals often would only be able to provide certain compensation packages that were very stringent, very strict, that were not very dynamic, reflective of the types of cases each provider was doing, as well as the demands placed on those providers. Post-pandemic, when we saw a lot of the private anesthesia practices become stressed financially as well as operationally, being unable to support financially their own practice, as well as recruit providers with a national shortage, we saw those private groups go under.
Mm-hmm.
And that created a market for both the PRN or the per diem providers, independent contractors, which we're seeing a large spread of that throughout the Northeast especially, as well as also having the providers move towards the hospital models. And the hospital models have become more transparent, have been able to reflect incentive-based compensation, which is a key for anesthesia employment going forward. And the hospitals have been able to adapt their models to attract these providers, notwithstanding the new legislation out there for non-competes, but also allow the anesthesia providers, if they do have a non-compete, it's now not geographically widespread as with a national company, but more focused on just a hospital. In most cases, the hospitals don't even have a non-compete or a non-solicitation clause in their contracts. So it allows the providers to maintain their place of practice where their families have grown up with the hospitals and surgeons they have worked with throughout their careers, with less stress, more transparency, and more importantly, compensation models are aligned with what they want to do with a work-life balance, as well as being rewarded for the work they're doing clinically, as well as engagement with the hospitals.
Well, and I'm sure it allows the hospitals to have more influence as to what's occurring with their providers. And especially if you have all of these dynamics around shortage and recruitment and so forth, you know, the hospitals may not be able to solve the problem, but at least they can influence it. Tim, when you're having conversations with your CFO counterparts or the administrative counterparts, what are they seeing as some of their economic opportunities related to employment?
You know, well, first of all, they're also sort of struggling with that, right? Because to Dave's point, they haven't done this with anesthesia. The staffing models are different, and they're really scratching their heads on what is the right way to do this? What's the right structure to have for my staffing models in anesthesia? I don't know how many MDs I need compared to CRNAs or even in some states AAs. And so they're really trying to figure out, where is my financial opportunity? I know I can't sustain what we're doing. These subsidies continue to increase, but I don't know how to restructure it, and what are my options for employment. Dave can speak to some various different models. It's not always with anesthesia, just employ or not to employ or to contract, but there's a lot of variables there of they can employ CRNAs, but maybe they aren't by state regulation allowed to employ the MDs. But there's a lot of hybrid models, and Dave, I think you can speak to some of those things of what you've seen and some innovative ways to structure it.
If you're just tuning in, I'm Daniel Marino. You're listening to Value-Based Care Insights. We're having a great conversation around the impact, both the operational, clinical, and financial impact of anesthesia related to some of the shortage and sort of that changing dynamic. Let's build off of your last comment there, Tim. Let's talk about what does that staffing model look like, right? So we're starting to hear, and have for the last couple of years, CRNAs are playing a larger role in delivering anesthesia services, but obviously not going to take the place of the physician. So what is that right complement, and how is an employment structure working through that, or managing it, or providing a little better solution? Dave, any thoughts?
Yes, and to your point, I think that all revolves around kind of the change in dynamics between the anesthesiologist and the CRNAs. The anesthesiologist has seen a role transformation post-pandemic into a perioperative physician, moving away from the clinician in the room providing one-on-one direct anesthesia care. With the growth of the CRNA schools and the CRNAs moving to a highly skilled set of providers with both regional techniques as well as anesthesia techniques, the CRNAs are expanding into roles of the one-on-one providers, doing that care daily to the patients from pre-op to post-op, where the anesthesiologist has been able to move to a perioperative role, managing the risk of the perioperative department, working closely with the perioperative nursing director, who in essence is running one of the largest P&Ls of a hospital by managing the perioperative environment and the surgical services. So by having them work together to manage risk, manage patient flow, to look for efficiencies, to look for ways in which we can improve the quality of care throughout the continuum of the perioperative process, that is the big change. And with that change comes a new employment model, because now that they were looking for a dyad partnership within the perioperative service, we are seeing the hospitals want to employ that perioperative medical director to align their incentives with hospital incentives to help drive these processes for higher quality, more efficiency, and a better financial impact for the hospital.
So the hospitals really do have to think about then sort of a two-pronged approach on recruitment. You want to make sure that you are recruiting the physicians, but also the CRNAs. Seems to me that the CRNA complement under the employment model would be, say, a 1 physician to 3 CRNAs, or 1 to 4, or 1 to 5, depending upon what that structure looks like. But economically, certainly as we adjust to the shifts in site of service of the ambulatory arena, in my mind, that's really where I think the rubber hits the road, and it becomes important to sort of overcome some of the shortage issues.
It absolutely does, Dan. And where the CEOs get worried is they don't know what is that. How far can you go? Can you go 1 to 5? And obviously it depends on what's going on in each OR. You're not going to have the same staffing ratio for all day for every single OR and procedure room. But how far can you go? And I'll tell you what is frustrating to the CEOs is in this dialogue where between the administration and the anesthesiologist is the anesthesiologists who don't want to see that change, who don't want to embrace the CRNA, in different staffing models. They push back and say, well, it's a safety issue. That's a quality problem. You're going to run up against, safety problems and create an unsafe environment. Well, of course, that panics any CEO. They're not going to, if the doctor plays that card, the CEO is not going to be the one that goes down for creating an unsafe environment in the OR. But they don't know. And so it takes someone like Dave, who knows this firsthand, to be able to say, no, let's talk through this.
Well, and CRNAs, to
let's
your
open
point,
it
they're
up.
not going to take the place of the physicians, but they're going to align within the care team. And I
Right.
think as the comfort level, the competency levels, and so forth of the CRNAs improve, that's where, again, then you're able to provide a larger, let's say, overall staffing model that would accommodate what the needs are of the organization. I want to talk for a few minutes around the economic opportunities here, right? Because at the end of the day, there's two important drivers, right? The clinical performance and the financial performance. We talked a little bit about maintaining that clinical performance with the right staffing model, but from the economic, the financial perspective, what are some of those, the key economic drivers that you're seeing that are influencing it, or what's creating the challenge right now? I mean, we're hearing all over the place that the stipends or the subsidies are really high and they grow year in and year out. What are some things that can be controlled by the hospital to ensure that the financial performance is aligned with the organization?
I think, and Dave will speak to this as well, I think one of the keys start with the actual contract or employment, relationship. That includes some incentive for the anesthesia providers to help drive financial performance. They need to have some skin in the game, and they need to be in a position where they are more in the driver's seat with leadership and taking some ownership of the ORs, because they're the ones who can make things happen on time, without delay, and help drive the financial performance of the OR. But they have to have some incentives and some skin in the game to be motivated to do that. So it's
Dave,
not
it's really
just
it's really the aligned incentives, right?
right, absolutely.
So Dave, what are some of the elements that you would include in an aligned incentive compensation model, or what are you seeing?
Yeah, so what we look for to do an aligned incentive compensation is we look at both the clinical aspects and the efficiency aspects, things that the anesthesia providers can control and align with hospital goals that are related to their incentives and their reporting metrics. So we look at efficiencies, we look at ways in which we implement, our ERAS programs to provide a more standardized, high quality, best practice approach to patient care, which allows for a decrease in length of stay, which helps all of us in terms of the cost of the system. We look at ways in which the anesthesia group can also affect postoperative pain through use of regional techniques. We look at ways in which the anesthesiologists complete their charting efficiently and effectively as to not hold up any billing or denial of claims because of inappropriate or inaccurate charting. And we look at ways in which we can engage the hospital. Hospitals want partners nowadays. They don't want a service, they want a partnership.
That's a good
help
point.
drive their process through. Now, what we do see on some sides is when we get these partnerships, sometimes the hospital may struggle on the aspects of the billing or the business side of anesthesia, as Tim mentioned before. And that's where companies such as the company I work for, as well as Lumina Health, can help kind of manage that aspect of the business to help make that more seamless as a transition and more transparent to both sides. So that's what we look for in terms of engagement. But the one thing I will state, though, it's very important that any incentives are completely separate from any type of billing or charges that the anesthesia providers create, because that would create, therefore, an issue with compliance legally. So that must be kept separate.
Compliance. So the compensation really needs to be on operational efficiencies, clinical outcome, performance, those things that really help to advance a lot of the perioperative surgical services. But at the end of the day, Tim, we have to be cognizant of the administrative activity. And I guess what I'm referring to is maybe you can speak to some of the revenue cycle challenges as well as the payer challenges. Revenue cycle for anesthesias is kind of own little animal, right? Do you feel like these hospitals, are they equipped to be able to provide the revenue cycle?
No, most of the time they're not, because the anesthesia has always been separate, right? And that's
Sure.
also part of the frustration, is the lack of transparency around the anesthesia billing. The administration is not familiar with the coding, which is a little bit different. They're not familiar with the billing, and all they suspect is that I'm paying this subsidy. I have no idea what you're doing on the billing side, and are you making any improvements, or are you keeping current, or are you just looking to me to just write that check because you came up short? And
Right.
so it's
Which
that.
ends up happening time and time again, I think.
Yeah, they just keep coming back to the well, right? That's how the administration feels, the CEOs. And they just realized, okay, I can't keep doing this, right? I'm just writing checks, and there's no accountability, there's no improvements. This just keeps happening. I had one CEO tell me that the contracted providers told him, hey, we think it's going to be a $4 million subsidy. Well, in Q3 of the fiscal year, they're $7 to $8 million, and he's thinking, what gives? I don't even know what's happening here. So they need some deep understanding, someone to study the revenue cycle and the management, and oftentimes it mostly comes from some outside helps, people who know this business and can understand it.
Yeah, well, and it's, the revenue cycle is so critical to the service. And, with anesthesia, it's a little bit, we've done quite a number of anesthesia revenue cycle assessments. And a couple of things that we always find out is those organizations who struggle with their revenue cycle the most do not have a good integrated process with the surgical activities. In other words, they don't get the pre-certification information. Their documentation and billing is not coordinated with the surgeons. I mean, those are really where we find the big crux of the issue. But also too, I think the reimbursement. I feel like a lot of times when hospitals start to employ anesthesia groups or anesthesia providers, they've not given real thought to their payer contracts, right? What they should be getting reimbursed. And without that, I mean, you really struggle. Dave, when we're thinking about managing or let's say starting to employ anesthesiologists, or even if they're independent, talk a little bit about how do they evaluate the overall improvement, or are there key performance indicators that groups should be looking at, or are there certain performance outcomes that ensure that organizations, as they start to employ these groups, are really, they're getting off to a good start?
Yeah, great question, Dan. And one of the things that's important is to understand where you're starting as an organization. Are you starting as an organization that is inefficient but yet has a low volume, or inefficient with a high volume, for instance? And each one of those creates a different set of challenges and a different set of measurements you would use. So a lot of times it starts with letting the hospital understand exactly how OR time should be used properly, both prime hours when everybody's costs are fixed, and also what is the cost of that off hours case, or that add-on case that may not have had the pre-certification that both you and Tim mentioned before. Therefore, we do the entire case and found there's no reimbursement. So we look in terms of where we are first as an institution or a facility. Then we base our incentives off of where we want to drive the process to.
Yeah, that's a great point. Well, gentlemen, this has been a fascinating discussion. I think something that I think we just scratched the surface and really discussing and diving into. Tim, if any of our provider listeners or anesthesia groups, if they're interested in understanding maybe some new solutions or some different ways of thinking about how they could better influence or manage their financial challenges with anesthesia, any thoughts, or maybe maybe you can provide your information? How can they get a hold of you?
Yeah, and that would be my one thing of sort of advice, Dan, is, and I know this sounds self-serving because we're consultants, but don't go it alone. This is the time to get some outside help. You're talking about millions upon millions of dollars that were not budgeted for, and you're not seeing a change in it. And oftentimes, in that hospital C-suite, even the CMO is not a surgeon, right? Like, they have a clinical background, and you need somebody who understands the ORs, And you need someone like Dr. Dave LeBec to be able to sit in there in the middle of it, and for us to bring both parties together and to identify not just the problems, but what are the solutions? Because like Dave said, there are solutions for these, and we know how to do that.
Yeah.
So I'd invite them just to contact us, obviously through our Lumina website, or find us on LinkedIn or anything. And we'd be happy to have the discussions and to assess it without even having to pose a fee or a charge for that.
Well, gentlemen, thanks for coming on the program. Love to have you back. Since this is such a top of mind topic for many provider organizations, maybe we can have you back and sometime down the road and dive into another topic. Think there's quite a bit to discuss, so never a shortage there. Great. Well, I appreciate it, and thank you to our listeners for tuning in. Until the next insight, I am Daniel Marino, bringing you 30 minutes of value to your day. Take care.
Are you at a crossroad with value-based care? Do you need to chart a future strategy or improve your organizational performance? Visit us at luminahp.com to learn more about our consulting services and leadership development programs. Also, you can sign up for our newsletter on our website and follow us on Twitter and LinkedIn. For more information about value-based care insights, visit the programs page on healthcareradionow.com or luminahp.com. Join the conversation using our hashtag VBC Insights. We are Lumina Health Partners. Thank you for joining us today. Until the next value-based care insight, stay well.